Hi, everyone. Thank you for joining us for our Crohn's and Colitis 101 Gutsy Learning Series webinar. My name is Sarah Gandaharian, and I'm the Manager of Patient Programs and Evaluation at Crohn's and Colitis Canada. Before we get started the webinar, let's run through some technical logistics. This event is being offered in English and in French audio. If you'd like to listen in French, please select the interpretation icon. It's a globe icon that's found in the Zoom menu bar, and you can select French as your language option. If you experience any technical problems during the event, please try refreshing your website browser or relaunching the Zoom webinar. You can also comment in the Q&A box that is also in the Zoom menu bar. I'll also give just a quick disclaimer ahead of today's talk. The materials in this presentation are for educational purposes only. They are of general value and may not apply to specific medical situations. These online resources are not a substitute for the personalized judgment and care of a trained healthcare professional. And for those of you on the call that may not be as familiar with Crohn's and Colitis Canada, I'd like to share that our promise is to find the cure of Crohn's disease and ulcerative colitis and to improve the quality of lives of both children and adults that are affected by these diseases. I'd also like to take this opportunity to encourage you all to register for our upcoming Young Adult Series. This event will be taking place on December 14th. And it would be a great opportunity for those of you that may like to get some more advice or tips on how to improve your mental health and wellness. This event is really geared for young adults that are aged 18 to 30, as well as caregivers to those that may be affected by the disease. This event will also feature a live yoga session and meditation led by a professional wellness educator. We also offer bi-weekly peer support events. It's another great opportunity to connect with other people that are affected by Crohn's disease or ulcerative colitis in communities from across Canada. You can scan the QR codes up there on the screen if you'd like to register for these bi-weekly events. The next one is on November 30th, which will be in English. And then we'll also have another event in French on December 20th. And as always, the information and the recordings from all of our Gutsy Learning Series presentations and webinars can be accessed on our website at crohnsandcolitis.ca/GLS. You can also, again, scan the QR codes on the screen there with your phone. And finally, before I introduce the speaker for this evening, and just another quick reminder that if you'd like to listen to this webinar in French, please select the interpretation globe icon in the Zoom menu bar and select the French language option. Okay, now we'll get started with the presentation. And it is my pleasure to introduce you all to our speaker for this webinar, Dr. Noelle Rohatinsky. Dr. Rohatinsky is an associate professor and a registered nurse at the University of Saskatchewan. She is also a committee member of the Canadian Inflammatory Bowel Disease Nursing Network and an esteemed volunteer with Crohn's and Colitis Canada for over a decade. Dr. Rohatinsky was our 2018 Ross McMaster National Unsung Hero Award recipient. Throughout her career, she has received various research grants, including from the University of Saskatchewan in 2019, Crohn's and Colitis Canada in 2020, and she also received the Saskatchewan Health Research Foundation grant in 2021. In collaboration with Crohn's and Colitis Canada, Noelle has hosted newly diagnosed webinars for people affected by IBD in her community and across Canada. And Dr. Rohatinsky herself was diagnosed with Crohn's disease in the year of 2000. We are very excited to have Dr. Noelle Rohatinsky join us tonight to walk us through an overview of what people with Crohn's and colitis should know about living with these diseases. We greatly appreciate Dr. Rohatinsky for leading today's presentation, and please take it away.
Great, thank you so much, Sarah. I'm just going to share my screen. Perfect. All right. It is my absolute pleasure and honor to be here tonight. Thank you so much to Crohn's and Colitis Canada for allowing me to speak to you about living with IBD. As Sarah mentioned, I have been living with IBD for 22 years, And, it's my passion to share my knowledge with you. We're going to be covering a wide variety of topics tonight, and we're going to be providing you with a general overview of Crohn's and colitis. There's a lot of information on the slides, but also I just wanted to let you know that the Crohn's and Colitis Canada website has a wealth of information. And if you want to know a little bit more detail about any particular topic, I encourage you to visit there. And to clarify, I'm not a clinician, so I do not treat individuals with IBD. So I may not be able to answer any very specific questions that you have related to your own personal experience with IBD. But we'll get started, and hopefully I'll be able to provide you with a little bit more information, more knowledge than when you started. So these are all the topics we're going to be covering tonight. And first off, we're going to start with a poll. So the question is, how would you rate your current knowledge of inflammatory bowel disease? And please go ahead and select the options there. Great. So looks like we have a wide variety of knowledge. Wonderful. Okay. So now we are going to be talking about what is inflammatory bowel disease. And I just want to start by discussing the digestive system very briefly, because that will help you understand the disease process that's happening. So we take in foods through our mouth, and it's transported by a small tube called your esophagus, and it goes into your stomach. Your stomach starts that digestive process and starts to break down the foods that we eat. From your stomach, it moves into your small intestine, and your small intestine is about 15 feet long. It absorbs, the role of the small intestine is to absorb nutrients from the foods that we eat. From there, it moves to the large intestine. And the large intestine is about 3 to 4 feet long, and its job is to absorb water. So this is, oftentimes we'll see individuals having lots of diarrhea, and that's because your intestines can't absorb that water. And malnutrition, nutritional deficiencies can be common, and that's because your body, because of the inflammation, it can't absorb those nutrients. But I'll back up and we'll talk more about that in just a little bit. With inflammatory bowel disease, inflammation of the bowel is the common denominator between Crohn's disease and ulcerative colitis. So inflammatory bowel disease is an umbrella term for those two diseases. Crohn's disease and ulcerative colitis are the most common types of IBD. And when your body, intestines, digestive system is inflamed, it disrupts your ability to digest food, to absorb nutrition, and to eliminate waste in a healthy manner. What's the difference between Crohn's disease and ulcerative colitis? There are several differences. Crohn's disease can occur from anywhere in the GI tract or the digestive tract, from gum to bum, so mouth to anus. And the disease goes through all layers of the bowel wall. If you look at the picture on the left, you can see that, so that picture is the stomach, the small intestine, and the large intestine. And you can see the patches of red. And those patches of red indicate inflammation and inflammatory bowel disease. So with Crohn's disease, you can see on the left that it is patchy. So there's diseased tissue, healthy tissue, diseased tissue, healthy tissue. So we call these skip lesions. So there can be normal, healthy bowel found in between sections of diseased tissue. With ulcerative colitis, it only occurs in the large intestine, rectum, anus, and only the innermost bowel layers are affected. And you can see by the picture that the inflammation is continuous. It extends upward from the anus and rectum up and along the large intestine. And remember, it's only in the large intestine. How common is inflammatory bowel disease? Well, Canada has one of the highest rates of inflammatory bowel disease in the world. 1 in 140 Canadians lives with IBD, and so that's over 300,000. Now, these numbers are expected to increase in the next, in the next 10 years, upwards of to 403,000. So what that means is 1 in 100 Canadians will be living with IBD by the time 2030 comes around. The disease affects males and females equally. It can occur in all age groups. It's most frequently diagnosed before the age of 30, but we see individuals diagnosed in their 80s. So it's all age groups. And we are seeing more and more diagnoses in children. It can affect any race or ethnic group as well. So no one is immune to IBD. It's very common here. We want to know a little bit more about you. So this is the next poll. How long have you or the person you care for been living with IBD? Wow, we have a nice mix of length of time here. Wow, lots of people, newly diagnosed, 23% less than a year, and 20%, 20 years or more. So wide, a nice, almost equal range of individuals there. So great, great. So what causes IBD? Well, we're not entirely sure at this point. There's lots of research in this area, but we know that it is a combination of these 4 factors, but we're just not entirely sure how they all interact with one another. So we know that there are individuals that are genetically more likely to develop inflammatory bowel disease. So we know that there's a gene factor. There are actually over 200 genetic mutations that are associated with the development of inflammatory bowel disease, and 2/3 of these gene mutations are shared with other immune-mediated diseases like psoriasis, like arthritis, celiac disease, ankylosing spondylitis, and type 1 diabetes. So there are individuals who are genetically predisposed, more likely to get IBD, and they come into contact with something in the environment. There are many suggestions as to what those some things might be. It could be one or more things, but we don't know specifically what they can't pinpoint it exactly yet. Come into contact with something in the environment, and it influences our gut microbiome. So what is our microbiome? Well, these are microorganisms that maintain our digestive health, and there are trillions of microorganisms living within our digestive system. bacteria, fungi, viruses, and that microbiome, something happens to that microbiome where it is altered in some way. And that alteration can affect our immune response. So that inflammation process turns on and we can't get it to turn off, or it's very hard to get it to turn off. So there's an interplay of these 4 factors, but research is ongoing related to all of these things, but we just don't know specifically, the exact cause. What they have been researching is risk factors for developing IBD and protective factors for developing IBD. And I'm not going to go into each of these individually, but there are some elements within the environment that make you more at risk for developing inflammatory bowel disease. And then there are some protective factors that prohibit or decrease your likelihood of getting inflammatory bowel disease. How do we diagnose and how do we test for inflammatory bowel disease? There are numerous tests, and I know a lot of you have probably undergone several of these tests already. So individuals will undergo these tests prior to their diagnosis, but also in their disease journey as well. Going through or having these tests will be able to tell you how active your disease is, where your disease is, are there any complications? And we can also monitor medication levels if you're on certain types of medication. So blood tests can be used to check for inflammation, infection, anemia, or nutritional deficiencies. They can also check for the amount of medication in your bloodstream and if your body has developed antibodies to medications. So our bodies, they might make antibodies because they don't recognize the drug. It's outside of us, it's inserted into us. And so they recognize them as foreign. And so antibodies are developed to protect us. So if you do develop antibodies to certain medications, you might have to switch those medications. But all of those tests are blood tests. So they are great resources to have and tell us what's going on for several different things. The next set of tests are stool tests. They can tell you if there's inflammation in the digestive tract. So you there's a stool sample and it's called fecal calprotectin, and it will tell you if there's inflammation in your intestines. Now, they might also do other stool tests. Maybe they think that you have a different type of infection, C. difficile infection. You could have a parasitic infection. So there's other types of stool tests where you would collect a stool sample that could test for other organisms as well. Endoscopic procedures. These are really the gold standard to diagnose IBD. And they can be, so what an endoscopy is, so it can either be a gastroscopy or a colonoscopy. And what that does is they insert a flexible tube either through your mouth or up your anus. And it has a camera on it, it has a light on it, and you can see the inside of the digestive system. And what's good about this type of a procedure is that you can, the specialist can take a biopsy or a tissue sample to look at the cells under a microscope. So this is how IBD is generally diagnosed, but it also can be used at regular intervals in your disease journey as well. There are other imaging tests that you might have been exposed to already. One of the tests that we don't usually or don't frequently use, but you might see, is a barium X-ray. So this is where you will either drink a thick white chalky substance, or it will be inserted up your anus and rectum, and they will take X-rays to see if there's narrowing of the bowel or any complications. And another imaging test that's very novel and non-invasive is an intestinal ultrasound. So it is, for anyone that's had an ultrasound, it uses a probe, you put it on the surface of the skin. So this special ultrasound looks at the intestines, and it's actually done by gastroenterologists who have trained, taken extra training. So it's not done by radiologists, it's done at the bedside at your appointment with certain gastroenterologists. And it's nice because there's not a lot of preparation. You can just, show up to your appointment and you get your results right away. It's not readily available in Canada, so there are very few numbers of gastroenterologists in Canada who use intestinal ultrasound, but you never know. They're trying to increase the numbers of specialists who do use this technology. The other two tests, CT scan and MRI. So these are three-dimensional images that look at all layers of the intestinal wall, and they can see if there's complications related to your inflammatory bowel disease. Okay, I just want to make sure I didn't skip a slide. No, okay. So now we're going to go to treatment. I just want to be clear at this point in time, there is no cure for inflammatory bowel disease. And treatment is very individual. It's very personalized. Everyone is different. So two individuals who have Crohn's disease may be treated in different ways, just depending on their own disease. But our goal with therapy is to reduce and control that inflammation and to induce and maintain remission, meaning that your disease is inactive. And we want to improve our IBD symptoms and improve our quality of life, which are very important as well. Medications and diet, we are going to be talking a bit more specifically in the following slides. Surgery can be used as a treatment option. 80% of individuals with Crohn's disease and 20% of individuals with ulcerative colitis will require surgery at some point in their disease journey. And there are many reasons why individuals may need surgery. Maybe the inflammation is really bad and the medications aren't quite working. Maybe there's some complications of inflammatory bowel disease, which I'll talk about in a little bit as well. So surgery is an option, but they try to, as best they can, treat inflammatory bowel disease primarily through medications. There are some emerging therapies that I just want to highlight, and more information is available on the Crohn's and Colitis Canada website. So the first one is the fecal matter transplant. You might also hear that as, FMT or stool transplant or fecal microbiota therapy. And so this is an experimental procedure where a healthy donor, so someone who doesn't have IBD, shares their stool, and the person with IBD receives the donor's stool, the donor's healthy stool. And the whole purpose of this is to restore that normal microbiome. So that diverse group of microorganisms that grow and flourish in our digestive system, that is the goal. And it's proposed that, or hoped that, FMT can induce remission in people living particularly with ulcerative colitis. They're seeing some good results, but it's ongoing and there's more work to be done. One of the other emerging therapies you might be interested in is medical cannabis. And more and more research is being taken up by researchers regarding the role of medical cannabis in IBD therapy. Many people living with IBD report relief of symptoms like pain, nausea, diarrhea, increasing their appetite, improving their sleep, and overall mood. We just don't have enough information yet, but I'm sure it will be a fast-growing therapy and topic moving forward. So if you are interested or curious about these types of therapies, please do discuss them with your healthcare provider, and they hopefully can provide you with some more information. So next, we're going to be moving on to medications. And just like treatments, no one size fits all for medications as well. So I have Crohn's disease. I'm on medications, but if I talk to somebody else who has Crohn's disease, they might be on different medications than I am. It really is individual, and it really can take time to find the right medication that works well for you and keeps your disease in remission. Sometimes you might be on more than one medication as well, a combination of medications. Generally, medication therapy is lifelong, and each medication has its own risks and benefits. So it's important when you are considering starting a medication or changing a medication that you discuss the pros and cons with your provider. Antibiotics are used generally not for long-term therapy, but more of as needed, and they can help decrease infection, and because infection can cause that inflammation. Antibiotics can be used for both Crohn's disease and ulcerative colitis, and the examples are listed there, the ones that are most commonly used. The next set of medications are the sulfasalazine and the 5-aminosalicylates, or 5-ASAs. And these are taken to reduce the inflammation, and they can be used to treat mild to moderate colitis. So you see here that they're generally only used for colitis and not Crohn's disease. You can take these medications by pill or by mouth or rectally as an enema or a suppository. Immunosuppressants. These medications suppress your immune system in order to reduce the inflammation, and they can be used in both Crohn's disease and ulcerative colitis. And these could be through injections or pills. And people on these medications, because they do suppress your immune system, it's strongly encouraged to get regular blood work when you're on this medication to monitor aspects such as your blood cell counts to see if there's any alteration with the blood cell count caused by the medication, or if there's any liver conditions that are developing because you're on these medications. The next class of medication are the steroids. So these can be taken to reduce inflammation, and they are used for short-term therapy, not for long-term. They do have quite a few side effects, so they don't like to use them long-term, but they work really quickly and really well to decrease that inflammation. And they can be used in both Crohn's and colitis, and there's several examples there. I think I'm just thinking if there was anything else I wanted to talk about steroids. It's important that you don't stop these medications cold turkey, that you taper them. That would be the only suggestion that I would have, but your prescriber or your pharmacist should let you know that information as well. The next class of medication are the biotherapies. So these are the biologics and biosimilars. And there's a long list there for you. These medications are, they target inflammation very specifically. So they target, very specific areas in your immune system to treat that inflammation. And they can be used in both Crohn's disease and ulcerative colitis. Blood work as well is typically done on a regular basis if you are on these medications to check for the, as I mentioned, the blood cell counts, the liver functioning, but also the drug levels as well, and the antibody levels. So just to see, are you, you get these medications. It could be every week, it could be every 6 weeks, it could be every 8 weeks, it just depends. And so they want to make sure that those drug levels are holding you until your next dose and that you haven't developed any antibodies. I just want to make a point here that there are 2 medications that are only used for either Crohn's disease or ulcerative colitis. So the first one is the risankizumab, and that is for Crohn's disease only. And then the other one that is only for ulcerative colitis is the golimumab, and the rest can be used for both Crohn's disease and ulcerative colitis. These medications are given either intravenously through your vein. They're administered in a clinic or a hospital setting. And then the other ways in which some of these medications can be given are subcutaneously, and that is through an injection, a self-administered injection into the fatty tissue, either in your arm or your abdomen, your stomach, or your leg. And as I mentioned, these can be given every, it just depends on the medication and the dose and you, but every week, every 2 weeks, every 6, every 8 weeks, for example. And then finally, the last class we're going to be talking about are the JAK inhibitors, or the Janus kinase inhibitors. And these are taken to reduce inflammation as well. These are taken, they come in a pill form, and they are only used in colitis at this point. So there's ongoing testing for Crohn's disease, but at this moment, it's only approved for colitis. Now we're going to be moving on to symptoms. Symptoms, I experience symptoms on a daily basis. I'm sure you all experience symptoms on a daily basis. They really can affect your quality of life and your daily activities. And symptoms are very individual. They vary between person to person, but they also come and go. So one day you might have no symptoms, the next day you do. If your symptoms get worse, well, let me back up. Symptoms are unique to each person, as I mentioned, but they're not always reflective of the degree of inflammation. So you may have symptoms and you are in a flare. Your disease is active. But sometimes you may have symptoms and your testing shows that there is no flare, there's no inflammation. Or your testing may show that you have inflammation, but you have no symptoms. So it can be quite frustrating at times to think, well, I'm having symptoms, but the tests don't show that I have inflammation. What's going on? What's important to know is if you are having new symptoms, or if your symptoms remain unresolved, that you let your provider know, because maybe there's further testing that needs to be done, or they might have some suggestions to help minimize those symptoms. We're going to be talking about how to manage some of the symptoms that you may be experiencing. So we have a whole list of symptoms. So diarrhea, loose, watery stools. So this is from inflammation of the intestines. And how do we manage it? You're going to be hearing me say this a lot. They recommend small, frequent meals. and adjust your diet if there are certain foods that are triggering for you for any of these symptoms. So keeping track of what you eat and how did you feel afterwards to try and figure out, are there certain foods that make your symptoms worse, give you more diarrhea, or make you constipated, for example. You will likely be on medications to help control that inflammation, but if you're not, your provider might put you on medications to control that inflammation. You can, under the guidance and advice of your provider, might use certain antidiarrheal medications as well to help with the diarrhea. You want to avoid dehydration, and it's easy to get dehydrated quite quickly when you have diarrhea. So drink water and use electrolytes to replace the fluid that you're losing. So consider something called an oral rehydration solution. So something like Pedialyte, for example. Ask your pharmacist to give you their recommendation. Constipation, I know this seems a bit uh, strange to have up on here, but it can happen with inflammatory bowel disease. Constipation is a common symptom. So it's inability to pass stools regularly. Stools are dry, hard, lumpy. You strain a lot when you're trying to pass a bowel movement. It could be due to inflammation in the rectum. It could be due to a low fiber diet. It could be due to low water intake or certain medications as well. So if if your intestines are inflamed, again, medications to help reduce that inflammation. Some other strategies are to drink more water. So important. So I always have to have a glass of water near me. It's really important to it'll help to soften the stool. Regular exercise, it helps to increase that motility of the intestines, so that movement of the intestines. Increasing your fiber is also recommended, or trying a bulking agent. So bulking agents are medications like Metamucil, or even something called lactulose that will pull the water into the digestive system to soften the stool and make it easier to pass. And don't hold or put off having a bowel movement. I know it's not always the most ideal time to have a bowel movement, but if you need to go, go as soon as you can. The longer the stool sits in the intestinal system, the more water can be pulled out of the stool, and the harder the stool can get. Blood in the stool, it can be alarming because it often looks like a lot of blood in the toilet. It can be part of an inflammation. And it's more common in ulcerative colitis than in Crohn's disease. So you might need a change in your medication to control that inflammation. You might need vitamin or mineral supplementation, such as iron, folic acid, and vitamin B12 to replace what you're losing. And you may need a blood transfusion as well if it is a lot of blood lost. Anal itching and irritation is common. So diarrhea can lead to that anal itching and irritation. Some strategies to help are using moist towelettes, the wipes, but alcohol-free, because alcohol will burn, so use the alcohol-free ones. Wash around the anus after passing stool, and avoid soap because it is quite drying. The other suggestion I have are to pat after a bowel movement, not wipe, rub, or swipe, sorry. Wear cotton underwear, avoid tight clothing to allow the area to breathe. And if it's really red and raw, you might need a barrier cream on your skin to protect your skin. And so certainly talk to a pharmacist if you need something to protect your skin if it's quite raw. Or practitioners can prescribe another, maybe another type of medicated cream that will help. Bloating and gas are very common and very uncomfortable. Some foods that you eat may cause gas. So things like beans, cabbage, Brussels sprouts can cause foods to be poorly absorbed or poorly broken down, and that can cause bloating. And it can also be from lactose intolerance. So a lot of individuals with inflammatory bowel disease are lactose intolerant. So your body can't break down those sugars, and so it causes bloating. So how do you manage bloating and gas? Again, eat small, frequent meals. Chew your food slowly. Avoid foods that contain or produce gas. Beans, onions, cauliflower, sugary foods, high fiber foods, raw vegetables, carbonated beverages, caffeine, alcoholic drinks. It's recommended to cook your vegetables as opposed to eating them raw. Again, keeping track of the foods that make you bloated. And again, everyone is different. Avoid sitting for long periods of time. So the more you get up and move around, the more your intestines will move themselves and you'll be able to expel that gas. Fatigue, very, very common symptom as well. It is present. So if your disease is active, 80% of people will be feeling fatigued, exhausted. If your disease is not active or you're in remission, still 50% of individuals are fatigued. So fatigue is very common. It's the reduced ability to maintain activity, difficulty concentrating. It could be related to inflammation. It could be related to nutritional deficiencies, anemia, pain, mental health conditions, lack of exercise, or even lack of sleep or sleep challenges. So there's lots of causes, and oftentimes there's more than one cause, right? So how do you manage it? Well, medications to control that inflammation. It's important to get blood work to make sure you don't have malnutrition, to make sure that your vitamin and mineral levels are good. And if they're not, then to get treated for those deficiencies. You might want to consider medications or psychological interventions to help with sleep, to help with depression or anxiety. And I know this seems counterintuitive, but increasing your physical activity can also help with fatigue because it creates those endorphins. Nausea and vomiting, how you manage those. So eating small, frequent meals, eat slowly, eat plain foods. So no spicy foods or high fat foods or very sweet, sugary foods. Avoid alcohol. Don't drink when you're eating a meal because that'll fill you up more. So just eat the meal. Avoid lying down after a meal for about an hour. Ginger can help, and avoid strong cooking odors as well. You can rinse your mouth with water or mouthwash to help clean your mouth. Now, if you're vomiting and if it is more than 24 hours, you have a fever, you have really bad abdominal pain, stomach pain, bloating, it could be an emergency where there's a blockage in your bowel, so go to the hospital. But if it's just a couple of times, or you're not really bloated, you might want to avoid solid foods. So try fluids, clear fluids, and if you tolerate, then maybe transition to things like white rice and white bread, mashed potatoes, oatmeal, crackers, those sorts of things. Loss of appetite, weight loss can be from nausea, can be from bloating, diarrhea, and even mouth ulcers. The way to manage that is through small, frequent meals, eating high calorie foods, healthy and nutritious foods. So what you do take in, make it count. If hot or cold foods bring on nausea, then, obviously try a different temperature food, and drink fluids throughout the day. And then also, of course, weigh yourself on a semi-regular basis just to make sure you aren't losing weight. Or if your pants are starting to become a little bit loose, maybe keep a closer eye on your weight. Sleep problems most commonly occurs during a flare, but can also occur when your disease is in remission. And some medications have side effects. So for example, steroids, take them in the morning because they can make you they're really stimulating. So if you take them at night, it definitely will not help with your sleep. So focus on relaxing activities before bed, sleep, try and have the same sleep wake cycle. Try not to take naps throughout the day. Avoid working or watching TV in bed. Read a book. Try meditation and mindfulness. Keeping a sleep journal as well. You can track your symptoms through this amazing app that Crohn's and Colitis Canada has created. It's called the MyGet app. And it tracks your symptoms. It can give you education resources. There's questionnaires to assess how you're feeling. And it can give you reports so you can provide that information to your provider. So it's very handy. Okay, so over the past 2 months, how often have you experienced any of the symptoms that we've talked about? Okay, so some days and most days are the most common. Yeah, good. And I'm envious of those that say never. That's good for you. All right, so moving on to pain management. Very common for individuals with IBD. It can also have a significant impact on your daily activities. So we're going to talk about some strategies for how to manage the pain. So it's important to know why you're having the pain. Where is your pain coming from? Or what's the source? So it could be from intestinal pain, pain from that inflammation that's occurring, but it can also be from outside of the intestines. You might have mouth sores, joint pain, skin conditions, or eye inflammation. Pain can also happen from complications such as scar tissue, infections, narrowing of the intestines, and functional pain. So functional pain is when you have issues with the nerves and the muscles of your intestines. So there's lots of different reasons why you may have pain. In terms of medications for pain, there's quite a few options. Acetaminophen, or the brand name would be Tylenol, for example, that would be the most recommended unless you have a liver condition. They do not recommend ibuprofen or NSAIDs. So ibuprofen, Aleve, Advil, they can actually trigger flares in some individuals with inflammatory bowel disease. So Tylenol is kind of your go-to daily pain reliever. You can be prescribed tricyclic antidepressants or SNRIs, which are selective norepinephrine reuptake inhibitors, and they help to block the pain signals to the brain. Same with anticonvulsants. They help to block those pain signals as well. So it's not that you have a seizure disorder. It's used to help with the pain. Anticholinergics and antispasmodics, they can help if you are having intestinal spasms. They can help with that. Opioids, you don't see offered frequently, so they are good for If you've had surgery and you're in the immediate recovery period, they could be prescribed then, but they don't use opioids for long-term therapy for individuals with IBD because it can actually increase your disease activity and cause increased pain. Medical cannabis, as we've mentioned before, is poorly understood, but some individuals believe and take it to help with their pain as well. So more information or more research is ongoing. There's other types of approaches that can be used in conjunction or separately, independently, with the medication therapy. So psychological and cognitive approaches, such as cognitive behavioral therapy, biofeedback, mindfulness therapies, those all can help to improve pain. And please don't be afraid to ask for a referral to a psychologist if you are interested in learning more about those types of therapies. Exercise is a great way to decrease pain, and it can help with improving, of course, physical functioning and well-being. And it doesn't have to be, running a marathon. It could be things such as swimming, yoga, walking, tai chi. It's any it can be any exercise or activity that you would like. And then diet and nutrition. So certain foods can aggravate the symptoms of your IBD, and so it's important to identify those foods, as I've mentioned. Another approach to manage pain could be TENS, so transcutaneous electrical nerve stimulation. And that's they deliver electricity to block the pain signals in that area. Therapeutic endoscopy. So if you or someone you know has a narrowing of the intestines called a stricture, it can potentially cause a blockage and cause pain. So one of the ways to treat that is to use that flexible fiber optic tube to um, open up that area of narrowing. And then surgery can also help with pain if if there's scar tissue or blockages, it can help to relieve that. But surgery can also cause more scar tissue. So there is they do use it, but they use it cautiously. I want to put a plug in for building your support system. I can't stress how important this is. Family, friends, partners are all important elements to your health and well-being. There are individuals that you can count on and share your experiences with. But sometimes, if they don't have IBD, they may not have a full understanding of what it's like. And so I also recommend online or in-person support groups for that support from individuals who know what it's like to live with IBD. And as Sarah had mentioned early on in the presentation, Crohn's and Colitis Canada does have online support groups. So I find that those are a great way to connect with others living with IBD. And of course, don't be afraid to seek professional help. So counselors, psychologists, psychiatrists, the great addition to your support system and your health and well-being. Just want to let you know about accommodations that may be available or that can be available to you. So if you are a post-secondary student, so if you're going to college, university, there are, if you have a chronic disease or you have we use IBD. So if you have IBD and your provider fills out a form, you may be able to obtain services or accommodations. So things like having flexible test dates, because maybe you're in a flare or having really bad symptoms one day. So you might have flexible test dates or submission dates for assignments. You might be able to write a test in a private room or close to a washroom, which is really helpful. And so there's a lot of different services that are available. So certainly do check those out at the university or college, and certainly at grade school as well. There are ways to do that as well. So just talk to the principal of the grade school for more information, or the guidance counselor. In terms of work accommodations, I think it's up to you whether you feel comfortable sharing you have IBD in the workplace. You can certainly keep your health information private and not disclose that information to your provider. But you might need time off for appointments, easy access to a washroom, maybe a chance to take a break when you're not feeling well. So I think it's, sometimes can be helpful to let your employer know, or even to see what your options are for at your workplace. There are complications that can occur for individuals with inflammatory bowel disease, and there are also extraintestinal manifestations. So these are um, uh, challenges or conditions that come up that are outside of the intestinal system. And so I'm just going to give you a very brief overview on them. So the first one is anemia. So this is a deficiency in your red blood cells or the hemoglobin in your blood. Fatigue is a common symptom of anemia. So it can be due to iron deficiency, blood loss, or low vitamin B12. So you can check it with a blood test. So if you are fatigued, certainly let your provider know and they can check for anemia. You might need iron supplementation or eat foods high in iron, such as spinach, liver, red meat, and legumes. You might need an IV iron infusion or vitamin B12 and folic acid supplementation. Malnutrition and weight loss, we have talked about that already, but it's important to test for vitamin and mineral deficiencies if you aren't eating as much as you normally would, or the regular foods that you normally would. Weigh yourself on a semi-regular basis, or if you feel like you're losing weight. Avoid foods that make your symptoms worse. Talk to a dietitian for meal planning if needed. And again, make your foods count. So if you're not able to take in a lot of food, maybe choose something with high protein, high calories. Even something like a Boost or an Ensure are helpful to get those calories in. Mouth sores, more common for Crohn's disease, and they're not sure, why they happen, but it can be indicative of active disease. So salt water rinses can help. Local pain medications where you can swish them around. Sometimes steroids can help as well. Individuals with IBD can have joint inflammation, so arthritis. Joint pain, stiffness, swelling are common. Some biotherapy and immunosuppressant medications can help with that joint pain and inflammation. As I mentioned, NSAIDs should be avoided. And, rest the joint, ice, elevation can help, but exercise can also help as well. So low impact activities, yoga, swimming, biking could help. And if you want to exercise, but you're having some joint pain, perhaps a different time of day is better for you. So maybe you're really stiff in the morning, but in the afternoon, your joints are a little looser. Talk to your provider if you are having joint stiffness, because they may want to refer you to a rheumatologist. Eye inflammation. So more common when your disease is when you have intestinal inflammation, you might experience eye inflammation. So some local medications can help. So eye drops and ointments can help decrease that inflammation. So it's important to see your optometrist if you do have vision changes. Osteoporosis is a weakening of the bones, so it causes your bones to become brittle and more increases your risk for broken bones. If you, excuse me one second. If you are taking steroids, you are at an increased risk of osteoporosis. If you are a smoker, and if you are an older adult, you're more at risk. So calcium, vitamin D, vitamin K are all important for bone formation. So supplementation may be necessary. Avoid steroids if you can. It's important to do weight-bearing exercises as well, and eating foods that are high in calcium and vitamin D. There are other medications that can be prescribed that can help promote bone formation as well. Skin conditions, two common medications are erythema nodosum and pyoderma gangrenosum, but there are also others that you may experience, such as psoriasis, eczema, that are a bit more common. So they can be treated with topical, so local medications, creams, ointments, and even steroids. So if you do have, you start to develop a rash, certainly that's worth noting to your provider. And liver conditions. So the one kind of main liver condition that I'm going to be talking about is primary sclerosing cholangitis, or PSC for short. And it's more common in ulcerative colitis, but what happens is your bile ducts, so your bile ducts help transport bile from your liver to your intestines to help with digestion. And those bile ducts become hardened and narrow. And so it can cause liver failure, it can cause infections and tumors. So it's really important that we do check the liver functioning on a regular basis. Colon cancer, so cancer of the large intestine, there's a slightly increased risk with inflammatory bowel disease, and the risk increases the more active your disease is. If you've had IBD for more than 10 years, if you are diagnosed under age 20, or if you have that primary sclerosing cholangitis. Sorry about that. How it's assessed for is that colonoscopy, and it would be managed with similar to other cancers, so surgery, radiation, chemotherapy. Mental health conditions, quite common. So there is a link between IBD and anxiety and depression and other chronic illnesses as well. And it happens even when your disease is in remission. So it's, certainly medical therapy, non-pharmacological interventions such as, cognitive behavioral therapy, mindfulness, meditation. Those things will all help to manage. Fistulas. Fistulas are small tunnels that can form from parts of your intestine. And so they travel to other parts of your body, like your skin, other organs, and they're associated with inflammation in your intestines. So management, some medications can help to decrease the size of the fistulas. Surgery could also be needed. Abscesses are pockets of infection, and they can occur with fistulas, and management are antibiotics and surgery. Adhesions are scar tissue that can occur from surgery, or most commonly occur from surgery, and it's mostly related to symptom management, is how we manage them. So you might need a muscle relaxant or a smooth muscle relaxant for the intestines. If constipation is an issue, low fiber diet actually might be recommended, or surgery. Strictures are narrowing of the intestines. So it could be from scar tissue, and it's more common in Crohn's disease, and it can lead to complications like a bowel obstruction. Management for strictures, surgery, that endoscopy with that balloon dilatation where you open up the stricture, or anti-inflammatory medications as well. Bowel obstruction, again, is a blockage of the intestine and can be a potential emergency. So it usually forms from strictures or adhesions. Symptoms are bloating, distension, nausea, vomiting, and lots of abdominal pain. And what you you'd go to the emergency room or the clinic. Um, Usually they will make you not have anything to eat or drink, or give you IV or a liquid diet only, and if needed, surgery. Anal fissures are small tears or lining of the anus. They can be very painful when you pass stool, and most fissures go away with time, but you might be prescribed medication or high fiber diets to help manage that. And then finally, hemorrhoids. Those are swelling or engorged blood vessels that are around your anus. They can be internal or external, and they can cause itching, pain, soreness, swelling around the anus. They can bleed when you're passing stool as well. So they can be treated with over-the-counter creams or suppositories. I know that's a lot of information, but there's a lot of information to go over here with the complications that you might have experienced. All right. Diet and nutrition always seems to be lots of questions related to that. There's no magical diet that can help with IBD, that can treat IBD at this point. So I'm going to give you some suggestions though. So a well-balanced diet is what's recommended. A variety of fruits, vegetables, and foods with omega-3 fatty acids, things like fish, cold water fish, tuna, salmon. Try to reduce or limit your intake of saturated and trans fats, red and processed meats, refined sugars, or highly processed foods or artificial sweeteners. So you want to avoid those things. When you are in a flare-up, when your disease is active, your diet may look a bit differently than if your disease is not, when your disease is not active or in remission. When you're feeling well and your disease is in remission, there's no limitations. What's important here is to develop an understanding of what your trigger foods are. So as I mentioned, keeping track of what foods make your symptoms worse. So you can keep track of them in an app, on a piece of paper, however you want. Most common trigger foods: caffeine, chocolate, spicy foods, alcohol, corn-based products, nuts and seeds, raw vegetables, lactose. I think I've mentioned most of them. Those are most common trigger foods, and everyone's different. So you have to find what your trigger foods are. So eating small, frequent meals, especially if you are in a flare, that's important, to just eat more regularly, but small amounts. Fiber is okay, except if you have a stricture or are in a flare. So don't be afraid of fiber. It can give you a range of nutrients, and it's important to drink a lot of water when you are taking in a lot of fiber. And there's two types of fiber: soluble fiber, insoluble fiber. So when people think of nuts and seeds and whole grains, that is insoluble fiber. So it adds bulk to the stool. Soluble fiber is things like oats, barley, beans, peas, lentils, and they pull water into the intestines. So it makes a little bit more watery of a stool. Softer stool, I should say. Fats are important, especially when you're in a flare or you're not able to take a lot of calories in. And there's some examples there. Protein, so meat, fish, eggs, beans, and lentils are important. Supplements and vitamin supplements, mineral supplements may be needed as well. Multivitamin, vitamin D, calcium, vitamin B12, all could potentially be important. Enteral nutrition, so that is a liquid diet, and could potentially be on it if needed, if you have a, if you are in a flare really bad, or you're just not able to take in enough nutrients. And there are specific diets that are still being tested to see, okay, did they decrease that inflammation? How, what is the impact of diet on IBD? So they're still being tested, they're still emerging, but you might hear specific diets, low FODMAP diet, Mediterranean diet, and the Crohn's disease exclusion diet are all diets that and researchers are looking to see what role do they play in IBD and decreasing that inflammation. Okay, so thank you for your attention. We are going to move over to the Q&A portion. So I'll maybe just let Sarah add her comments in now.
Thank you so much, Noelle. That was such a wonderful presentation, super well-rounded. I know there was a lot, everyone on the call. Just want to remind everyone that we will send a link directly to this recording after we post it on YouTube and our website. So we'll try to get that out to everyone, within about 24 hours after the end of tonight. So thank you again for submitting all of your questions as well ahead of time. There were a lot of really great questions that came through. We'll try to get through as many as possible. We are going to try to end on time. So if we can't get to your question, then I would encourage you to email us at learn@crohnsandcolitis.ca. So we'll share that email in the follow-up email that we send everyone tomorrow, along with the link to the recording. And we'll also share that email in the webinar chat. So let's get started with the Q&A. Okay, so for the first question, once a treatment plan has been developed, which tests and how frequent should these tests be completed are recommended to monitor IBD activity and long-term risks like cancer? I know, Noelle, you reviewed some of the tests, but are there any in particular that are done maybe on a more frequent basis and specifically for looking at risks like cancer?
Yes, this is a great question. I think routinely what you will see is a complete blood count. So to look at your inflammation, to look at your risk of infection, so testing for anemia, so that common condition. Testing for nutritional deficiencies as well is quite common. And if you are on a biotherapy or immunosuppressant medication, doing liver function tests or even tests for the drug levels within the bloodstream and the antibodies to it. The other tests you might frequently experience are the stool tests. One of them is called the fecal calprotectin test, to look for that specific inflammation in the stool. And then finally is the colonoscopy. And this is where they can monitor for things like colorectal cancer in terms of taking the biopsy in that colonoscopy. So they can also see the intestinal lining and see if there are polyps or other areas that look unusual that they need to do some further work on. And the frequency of these tests really depends on your symptoms and your degree of inflammation. And it depends what medications you're on as well, because if you are on those immunosuppressants or those biotherapies, you might have those blood tests every 2 to 3 months. Whereas if you're not on them, it might be every 6 months for blood work. So it really, as with most things with IBD, it depends.
Okay, great, thank you. And so I guess people should speak to their healthcare provider if they have any concerns or questions about how frequently they should be getting tested. Okay, next question. What is the value of taking medications as compared to trying, non-medicinal or non-pharmaceutical types of approaches when being diagnosed with IBD?
What's important to remember here is the essence or the underlying essence of inflammatory bowel disease is that inflammation. And the only approach to date that has been proven to decrease and eliminate that inflammation is medication therapy. So that being said, there are non-medication therapies that can help with improving symptoms and quality of life. So personally, I think management is really a combination of those two approaches, and both work together or synergistic to enhance the quality of life and decrease that inflammation.
Thank you. Next question. I have been maintaining a state of remission with a strict diet and medication plan, but am still experiencing unexpected flare-ups. What could have caused these flare-ups to occur?
There is no easy answer for that one. Sometimes, despite our best efforts, flares happen. So it's nothing that you have done. It's just, sometimes these things just happen. But talk to your provider. Perhaps there needs to be more investigation because you might, yes, you're experiencing these symptoms. But why? Where's the source? So you might need blood work or stool tests or even medication adjustments because maybe your medication was working and now it's just those levels are just kind of fallen off a bit and you just need a bit of a medication increase or an adjustment to help with that. So it's really hard to know why someone's in an unexpected flare, but certainly further testing is needed. So talking to the provider is recommended.
Thank you. Next question. How can I best communicate my needs and connect with my IBD specialist?
Yes, from my research, I hear, and I'm a patient myself, that a lot of persons with IBD feel that they are not listened to or not heard, and it's so tough. You have, that 5 minutes in that appointment to get all of your needs met, and it's so difficult. So this is such a great question. Knowledge is key. I think you learn as much as you can about IBD. Keep track of your symptoms, know your medications, get, blood work done or other testing done when it's recommended so that you can be as knowledgeable as possible. Come to appointments with a list of questions. Keep it by your bed or keep it in your office where you can just write questions down. Don't be afraid to ask questions as well. This is your illness and your experience, so ask those questions so you have a better understanding. And if you're a little bit nervous talking to your provider, practice asking those questions with someone who you trust in advance, or even ask, others who have IBD what questions potentially are good questions to ask your provider. Bring a support person to your appointments. That's always helpful to have another pair of ears to listen and ask questions. And I would say be the squeaky wheel. We are our own best advocates for ourselves. So yes, be that squeaky wheel and don't be afraid to ask those questions.
Thank you. That's really great advice. This is a question that we get often. And then people are sometimes frustrated. So I
Yeah.
think, I love the idea of, having a notebook or having, a notepad there with questions just as to serve
Mhm.
as a reminder when you go to your appointment. Yeah.
Well, Sarah, I think,
Yeah.
I think it's important because we all think of these great questions. Maybe it's in the middle of the night or, not
Yes.
at the appointment. And then we get there and it's a challenge to find parking and all those things. And we come
Totally.
a bit flustered and we've forgotten our questions. So yeah, it's a great
No, that's
strategy.
yeah. Yeah. Very good point. Very good point. Thank you. Okay. The next question is, what are the points to consider before opting for surgery in IBD?
It really depends on the situation. Sometimes there's no other option but surgery. Maybe you have a complication that, a bowel obstruction that cannot unfix itself, right? Or cannot fix itself. Or maybe you have a narrowing that needs to be fixed. So yes, sometimes there's no other options, but ask questions. Have that support person with you when you are at appointments. And if you know you might need surgery and you're going for a surgical consult, so you're going to see the surgeon, uh, again, um, bring that support person with you, write down those questions, and ask the provider, are there any other options besides surgery? I think that's always a good question. Or what if I don't have the surgery? What would happen? So kind of know all aspects and to be fully informed. And in terms of preparing for surgery itself, if you know you need to have surgery, if you can maintain your health as best you can before surgery, it leads to better outcomes after surgery. So making sure, you know, increasing your protein in your diet to increase your weight, right? You want good reserves in order to recover well. Um, just maintain that good overall health. Exercise, whether it's going for walks, just to keep your strength up, because surgery takes a lot out of a person.
Thank you. Next question. Do you have any advice on how to adapt to life after having a bowel surgery?
Well, surgery is absolutely an adjustment. It's important to be kind to yourself, because it will take up to at least 6 weeks to recover for your body to heal. So you're not going to be able to jump off the couch or the bed and carry on just like you were doing before surgery. It will be slow. So be kind. um, Depending on the type of surgery you have, there may be some diet adjustments that are needed. And so it's important to ask if you need to alter your diet in any way after surgery. And I'm thinking particularly for those that have an ostomy surgery, there are some limitations with the diet. So that's where the bowel is brought to the surface of the skin, and you expel stool from your skin. It's how it sits in a collection bag. But there are some diet limitations with that. And then just some general after surgery care. When you're coughing, hold your incision with a blanket and a pillow, and while you cough, so that it's less strain on your incision, keeping that incision clean and dry. Making sure that you're following up with your surgeon and your gastroenterologist or whoever your healthcare provider is. So don't miss those appointments if at all possible. And just practical things like, prepare meals in advance, or have support people drop off meals so you don't have to worry about that, or having support with childcare, and with cleaning, if at all possible. People want to help, and those are ways in which people can help you, right? So you'll have people that'll be asking, what can I do? Take advantage of those things. And talk to others who've had surgery and get their perspectives. What do they suggest, how best to manage after surgery?
Some great advice, and maybe I'll use this again as an opportunity to plug in for our Gutsy Peer Support Program. We do have trained mentors that have gone through the experience of having surgery, and as Noelle mentioned, being that additional layer of support to know what to expect, and they also may have some additional advice to share on how to adapt. So encourage you to reach out to us for that. Okay, next question, please. How can the transition of a teen with IBD into adulthood be better facilitated?
This is also a great question. And again, I'm going to be now putting a plug in for the Crohn's and Colitis website, because they have really great videos from an amazing nurse, who provides you with tips for that, to facilitate that transition. It is a process. And it doesn't just occur in one day. It is in fact a process that can take months and years to prepare for. And it's better if there is a structured transition program in place. So asking your provider, is there that structured transition program? And and if it is, you will be able to participate. The timing of that transfer should be flexible based on the young adult's abilities, developmental abilities and needs. But all children actually need to be moved to adult care by 18. And so it's important that there's collaboration and communication between the young adult, the caregivers, and the providers, both the pediatric providers and the adult providers. So it's, sometimes if you are part of a program, there's that joint clinic that can occur where you come together and you meet. Other times, because it is an adjustment, you go from team-based care in pediatrics to, just an appointment one-on-one with your provider. So it can be quite intimidating. In terms of assisting with transition, it's important to allow young adults to get that progressive independence and start as early as you can, depending on your own child's abilities. So do they know their medications, the dose? Do they know where their disease is? Are they comfortable asking questions of the provider team? So encouraging them to develop those self-management skills is really important. Even knowing when to fill your prescription, or how to ask questions of the provider, or how to schedule appointments. So there's lots of different factors that need to be considered and supported. Even using, the app, My Gut app, to track symptoms or medications, or, teens do like the apps. So I think, that could help. And peer support as well, I think, it's really a challenge to maybe move out on your own, start university life, also dealing with a chronic illness. It's overwhelming. So having that peer support is important as well.
Yeah, it definitely can be an overwhelming transition, definitely into adulthood. And thanks, Noelle, for mentioning the additional resources on the website. We have had a few presentations similar to the one this evening, webinars on this very topic of transitioning the care of a child going into adulthood. So we will be sure to follow up again tomorrow with a link to the additional Gutsy Learning Series presentations that we've had, where you can access those videos on YouTube. Next question, please. And I think this will probably have to be the last question for this evening. And again, just as a reminder, if we did not answer your question, please do email us at learn@crohnsandcolitis.ca, and we'll follow up with you. Okay, so the last question is, I have been diagnosed with IBD while on maternity leave. Do you have any advice on how to feel more comfortable returning to work with this new diagnosis?
That is a loaded question. These are two really big life adjustments happening at once. Be kind to yourself, I think, is always my suggestion. But consider talking to your employer or a trusted coworker about your new diagnosis, and talk to others who have IBD, because they might have suggestions. So online supports, to know how to navigate that, because there really are two complex, challenging adjustments happening at the same time. You may be more tired, not only being a mom, but having IBD. It's a lot. It's a lot. Long work days that you're, that are an adjustment as well. Rest, of course, when you need. Ask for help. Pre-planned meals are just some of the things I can think off the top of my head, but hang in there.
That's really great advice. And yes, that is a lot to be dealing with at one point in time. But we are here to help. Also, there are some resources, to help with support in the workplace. I think Noelle had mentioned, there are those accommodations. So if you want any help navigating those resources, again, please reach out to us and we can help with that. Okay, so I think we'll maybe advance to the last few slides as we wrap up this evening. Again, there were some questions that we weren't able to answer, but we would like to finish with the last poll question, just to gauge how maybe your knowledge around IBD may have changed since Noelle went through her wonderful presentation with us. So we'll leave the poll up there for a little bit there, and we'll then share the results with everybody. From what I can remember, I think it was a little bit more on the very low, sort of moderate side of things. Okay, so let's share these results. Okay, so it's looking like there's a shift. Okay, there's a shift to the majority saying high or very high, and some still in the moderate phases. So for those that are still in kind of that moderate level of knowledge, again, we will be sharing this recording, and maybe you can go back to it as a refresher. So again, thank you so much, Dr. Rohatinsky, for joining us. It was such a wonderful presentation, lots of really valuable information that was shared. And again, you've been doing these webinars for such a long time with the organization, and so we really appreciate all that support and great advice that you've given. And again, everyone on the call this evening, thanks again for all of your questions and for tuning in. And please do email us at learn@crohnsandcolitis.ca. The email is up there on the screen. When you log off of this webinar, there will be a survey that's pushed to you through Zoom. It should only take you 60 seconds or less. There's 3 questions there. We would really, really appreciate your feedback. We do take a look at everyone's comments and try to integrate that into future webinars to improve the experience. So thank you for your time. And a special thanks to BG Communications for providing us with live French interpretation this evening as well. And if you don't already, please follow us at Get Gutsy Canada. We are on Facebook, Twitter, Instagram, TikTok, all of those, the great social media networks. So please, if you're again looking for additional resources or you just want to stay up to date, following us on those channels is a great way to do so. And thank you everyone again. And I hope you enjoy the rest of your evening. Bye for now.